like I said last week, we're kind of reversing chapters 4 and 5. We're going to talk about chapter 5 today, and then on Thursday, we're going to review chapter 4. Thursday, when we review chapter 4, we're going to start doing a lot more hands-on practice. So if you have a code book, you'll definitely want to bring it in. I have copies up here if you guys want to use them and share them, because I want you to get used to the process of looking things up. After these first 5 chapters, chapter 6, we're actually going to dive into going through the specific tabular chapters, learning the rules of those chapters, and looking up codes, how you find codes in those chapters. So we're going to start that next Tuesday. I'm actually not going to be here next Tuesday. I have a conference that I'll be at, but Ms. Buck is going to be in here with the WOTC students, regular students. You guys are welcome to join her if you'd like. I will have the recording available on Blackboard for the lecture for chapter 6 on Tuesday. So you'll be able to go in, watch the lecture, and do your assignments for chapter 6. And then chapter 7 on Thursday, I'll be back in here and we'll kind of review those chapters. I also have to mention I haven't taught this class before. So once we get into the chapters and we start actually coding things out, we'll kind of take a poll from you guys and see what's the best approach. If you want more hands-on and we can all follow and find things together in the classroom and you review the lectures at home, kind of we'll look at what works out best for you guys with that once we get into the actual chapters. This information at first is just kind of the rules of it that we're talking about now, but once we start practicing, we'll get into it. Did everybody sign in? Let's hear. Okay. I do have to do my attendance really fast. Notes to pull up here, and we will start reading chapter 5. When they put in the new computer system, we realized that the presenter view is no longer available, which doesn't mean a lot to you guys, but usually I write my little notes on the side, and I could see them up here before, where you would just see this, I would see that and my notes. Well, now I can't see my notes because they changed the projector, so that's why I have to use the iPad so I can read my notes while having you guys project up there so you don't see all of my little notes that I prompt myself. Okay. Things about to explode. Diagnostic coding guidelines. So we kind of talked about this information already. So a recap of how these guidelines, reporting guidelines and codes were developed, because there is a question on the quiz about this, or the test yourself, so I wanted to put that reminder out there again. The Centers for Medicare and Medicaid Services and the National Center for Health Statistics are the ones that developed these guidelines. Whereas these organizations are the partners that help with it. They're not the ones that developed it, they are the partners. There's going to be a question that asks you, did HEMA develop these guidelines? HEMA did not, they were a partner, whereas the Center for Medicaid, or Medicare and Medicaid Services and the National Center for Health Statistics are the ones that actually developed the guidelines. We've reviewed some of the guidelines, all the guidelines that we have reviewed so far. We went over the coding conventions. And kind of the basic coding rules were all in section 1 of the guidelines. As I mentioned, the PDF file for the guideline is available under your resource tab on Blackboard. It's about 120 pages and it includes all 4 sections. So today we're going to kind of talk a little more in depth about the different sections. Section 1, we're really just going to talk about the general coding guidelines. We're not going to talk about the chapter specifics yet. We're going to talk about the chapter specifics once we get into each chapter. The conventions we talked about with chapter 3 last week. So we're just going to do the general coding guidelines in section 1. Section 2, the selection of the principal diagnosis for non-outpatient settings. So this is really important when you're trying to code out information. What do you list first? So that's the principal diagnosis. We'll talk about those. Section 3, reporting additional diagnosis. And then Section 4 is the guidelines for outpatient services. So outpatient services and inpatient, they have different reporting guidelines. Your inpatient ones are going to be a little more, they're a lot more in depth. There's a lot more that goes on with your inpatient versus your outpatient. The outpatient section is a lot smaller. It's a little shorter guidelines, and they follow a few different rules. When you're looking through your code book, when you're in the tabular and you're finding different information, you're going to see little notes next to things throughout that'll say something like C section 1C21. Anytime you see that, that is referencing a specific guideline within these coding conventions and guidelines, and it'll tell you where to go. So section 1, so you're going to go under section 1, you're going to look for C in the index, and then number 21. So everything is outlined in the guidelines, so that way you can easily reference it. If you're not sure if there's something that's going to be specific about that one, it almost always is going to have that C section, so that you can reference that note to know what to do in that situation. So the book does give you a lot of details and information. When you see a specific code, it will reference you back to the guidelines, so that way you make sure that you are following the rules appropriately for whatever code that is that you're looking at. And this computer sounds like it can explode. Can you guys hear that? Okay. Hope it doesn't explode. Okay, so let's start off with the section 1 guidelines. Like I said, this talks about the structure, conventions, and general guidelines and the chapter-specific guidelines. The chapter-specific guidelines we're going to dive into when we get into the chapters, but some of the general coding guidelines I have listed here. One of the first ones is the diagnostic codes are to be used and reported at their highest number of characters. So we mentioned that a little bit, where your codes can be anywhere between 3 and 7 characters. But they need to be at the highest level for the detailed information that's provided.
Chloe's in this class, right?
Chloe, yes. The 3-digit codes that are used as the heading, so when you look in the different chapters, you'll see 3 different codes. Heading, those are the categories, denote the category for those codes. And it can be that the highest level of code that's reported is just a 3-digit code. It depends on the information that the report has, that the patient document has, as to how far in depth that you'll actually go. But a 3-digit code could be the highest level depending on that information. It can go up to 7 digits. I told you I'm kind of losing my voice. Additional general coding guidelines. Codes that describe symptoms and signs are acceptable. So if it doesn't have a specific diagnosis, you can just code the symptoms and the signs that are associated with that if a diagnosis has not been listed or is not established. That is okay to do. If something's not specifically listed on there, you can code just the symptoms of it. However, signs and symptoms that are associated with the disease and that disease is listed, then you do not report those signs and symptoms. So for example, the documentation has a code and a fever, and the diagnosis is respiratory infection. You would only code respiratory infection. You wouldn't code the fever and the cough. But if just fever and cough were listed and the respiratory wasn't listed, it wasn't diagnosed, then you would record the fever and the cough. Does that make sense? So if there's the disease is reported, then you don't need to include the symptoms of that disease. But if the disease is not reported, then you can include the symptoms of it. Additional signs and symptoms that have not routinely been associated with that disease should be coded. Something like this would be a patient comes in with a broken ankle and vomiting. Vomiting is generally not associated with a broken ankle, so you would code the vomiting as well as the broken ankle. If it was something like a respiratory infection, they came in with a cold, a fever, diagnosed with a respiratory infection and a broken ankle, then you would include the broken ankle or swelling in the ankle, something like that as well, because it's not something that is generally associated with that disease. There are several instances where you're going to use more than one code, or you may just use one code. So multiple codes are definitely needed if the notation says additional codes are needed. So the notes that we reviewed last week, if it says use additional code, code also, code first, then you're going to need more than one code for those. When a code first note is listed and an underlying condition is present, you're going to code the underlying condition first. So it kind of is as just a different rule there. And I will also kind of note, I was trying to give you a little help on your exams, and I think I caught all of them. Things that are underlined and bolded are things that you may see on the exam when you go to take that. So when you're referencing the notes, I tried to highlight the information in the notes so that way you kind of had that reference when you were going back, kind of refreshing yourself on the quizzes. So if the same condition is described as both acute and chronic and separate sub-entries exist, then you would code both. So for instance, if it says the patient has acute and chronic, whatever the condition is, you would code acute disease and chronic disease. So you'd have both, with acute listed first. However, it just really depends on when you get into that disease, because some of them are going to be listed differently. And I have one that I'm putting in for the notes for next week, where chronic is listed as a non-essential modifier. So it doesn't matter on that one, but acute is actually listed as a separate code. So in that instance, you would just code the one. So you'll just have to look at the notes. If the notes say acute and chronic, and when you go through your index, if acute and chronic are listed separately, then you would code both of them. If they're listed together, non-essential modifiers, then it would just be one code. So it depends on the condition that's listed, how they have the acute and chronic listed out there. But if both are available, then you always want to put acute first rather than chronic. Combination codes are codes that are used to identify more than one diagnosis or a diagnosis with a complication. So it's just one code that kind of covers both things. For instance, high cholesterol with high triglycerides is one code. You wouldn't code high cholesterol and then separately code high triglycerides. There's one code that covers both of those. And you'll see that when you get into the index, when you start, when we practice and you're looking at the main terms and you start looking at the modifying terms, you'll see that that's available as a modifying term and that there's going to be one code that's available for it. If that modifying term isn't listed there, then it would be a separate entry that you would want to look up, a separate code that you would look up. It wouldn't be a combination code. A sequela, if I said that right, sequela, is a late effect. So this is, Sarah, you actually mentioned this, what happens if like something happens after an injury. So it depends on the situation, but a late effect is a residual effect after the phase of an illness or injury. So what happened after the fact? In this instance, you generally are going to do both of them. You're going to do the main condition first, list that first, and then you're going to do the side effect second. So if you think about a scar formation from a burn that you would have, what would be the condition, the first condition that happened? The burn. So you list the code condition first, so you list the burn first, and then the residual effect would be the scar that formed from it. So it's the order that you would list those. And if a documentation has impending or threatened as the condition, so it doesn't say specifically, it says impending or threatened ABCD. You want to review the index under impending or threatened, those terms, to see if there is a separate code for that. There's not a lot of these. Most of them are, they do have to deal with the pregnancy chapter. So if the documentation says it was threatened labor, you wouldn't go just to labor, you'd go to threatened and then to labor. So there's just a few terms, just these impending and threatened. There's think it was like maybe 8 conditions between the two of them. And if you look up in the index just under impending or threatened, you'll see that there's just a small portion of those. But if you see either of those terms, then you do want to go to those first to see if you code from that section under threatened or impending. If it said threatened break, and you go look under threatened or threatened fracture, and you look under threatened and fracture is not available, then you would go to fracture. So it's kind of just to check yourself. Once you get used to and you see what's known as impending or threatened condition that are coded, again, because there's not a lot of them, and then you don't have to reference that every time. But anytime you see those terms right now, until you get used to it, go to the impending or threatened first in your index, and then follow the guidelines from there. Borderline diagnosis can be coded as a confirmed diagnosis unless there's a specific borderline code listed for that. So kind of the same example, if the documentation says borderline high blood pressure, if you go look under blood pressure, high, there is a borderline option available. So you would code specifically to borderline. But if it was a condition that did not have borderline available, you would code it as if that condition existed. So if it was, you went to blood pressure, high, borderline wasn't available, you would just code high blood pressure. That makes sense. Each diagnostic code may be reported only once for that specific encounter for outpatient, so think of inpatient care. That code can only be reported once. This is a little bit different than your inpatient care, because your inpatient you can code as many times as that happens. So in the hospital setting, it's just you can only record once for the encounter. For situations that have bilateral sites, so think of left and right, more than two sides of the body, the final code of that code is always going to indicate laterality. So it's going to tell you is it the left side or the right side, or both sides if it's bilateral, or unspecified, depending on the situation that's there. So if it says the patient had cataract surgery, both eyes, and you've coded in the index, you went to your cataract and left, right, and bilateral are available. If they had it in both eyes and bilateral is an option, then you would just use the one code for bilateral to do both eyes. If it only happened in the left eye, you would just select that one. It only happened in the right eye, you would select that one. If it doesn't say which eye, if it just says cataract surgery, doesn't tell you the eye, doesn't say both eyes, anything like that, then that would be when it would be an unspecified, or you'd query the physician in that instance, because you need to know which eye it happened in. It's just that the documentation kind of wasn't there. If bilateral is not available, if it only has left and right, it doesn't say bilateral, then you would code both of them. So again, in the eye situation, if they said both eyes, but there wasn't a bilateral code, then you would have one code for the right eye, one code for the left eye. You'd have two different codes in that situation. Additional kind of things that may come up: body mass index, depth of non-pressure ulcers, pressure ulcer stages, coma stages, and the NIH stroke scale may be coded based on qualified health notes other than the provider, other than the doctor. So most of the documentation that you're actually going to be reporting is going to be from the main provider, the physician notes, the encounter form, that information. However, this information can be taken from other documentation. So think of the nursing notes. For instance, the patient was admitted, the nurse did Bosmati index, their height, their weight, and determined that they were, their BMI was 45%. And that was documented in the notes. The physician has listed that the patient is obese, so that's the diagnosis. The physician listed the patient was obese, but they didn't report specifically what level, that 45%. It's okay to report that 45% out of the nursing notes. So you would only do the diagnosis from the patient. So the nurse couldn't document, obesity as a diagnosis, the physician has to diagnose that, but you can document the index or the scale that they're at based off of the nursing note. So for additional detail, that's listed there. Say that the obesity wasn't diagnosed, but you're going through and you're coding out the information that happened, and the body mass index was made available in the documentation. You can code the body mass index as it's listed, but you can't add the diagnosis. You just list the 45% index based on their age. You would not add in the obesity if that was not something that was listed. And these are always reported as a secondary code. These are not going to be your primary diagnosis. So the body mass index may be listed at the 45%, but that's not your primary code. The obesity would be your primary code. So that kind of wraps up the section 1, the general rules. There are going to be a lot more rules. Again, if you look through those 120 pages, the majority of that, those guidelines are going to be the chapter-specific guidelines that we'll break down when we get into each chapter. The big majority of that is going to be the chapter-specifics. Section 2 is talking about the selection of principal diagnosis. Principal diagnosis, there's 2 terms. You'll see section 2 where we're talking about selection of principal diagnosis. This is for non-outpatient settings. So as defined in the guidelines, non-outpatient settings include acute care, short-term care, long-term care, psychiatric hospitals, home health, rehab, and nursing homes. So kind of think of it as not just your regular doctor visit in and out, not a rehab setting where you're in and out. Think of something that's a little bit more long-term care or urgent care is going to be what's more included with your non-outpatient setting. Where your outpatient setting is going to be like your basic doctor visit type thing, your in and out type stuff. A principal diagnosis is pretty much, your principal diagnosis is what is coded first. It is defined as a condition established after the study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Pretty much when you hear principal diagnosis, you always want to list your principal diagnosis first. Your principal one is going to come first, your secondary ones and additional codes will come after that. As we break into each chapter, just when we get to chapter 18 specifically, chapter 18 deals with symptoms, signs, and laboratory findings, so testing results. These codes from chapter 18 are never used as a principal diagnosis. They're always going to be an additional diagnosis, so you're not going to use the laboratory test as a diagnosis for high blood pressure. That needs to be documented, not just the test listed there, that the physician has found from the testing that high blood pressure exists. So it still needs to be documented. It's not as a coder, it's not your responsibility to pull out and say, okay, this test showed high blood pressure, so I'm going to document high blood pressure. You're adding additional detail to that. So the test results should never be listed as your principal. It's just kind of your supporting evidence that you would come along with it. 2 or more conditions that could both be the principal diagnosis, or 2 or more that equally meet the definition of principal diagnosis. If situations such as this happen, then you can tag either one as the principal diagnosis unless there's that code first note that is applied. So if a patient is presented with vomiting, nausea, stomach pain, and the testing confirms that they have an ulcer and an inflammation of the intestines, you could list ulcer or inflammation as the principal because they have both of them based off those results. So it doesn't matter which one you list first, but you would need to list both of them unless there is one code, that combination code that covers both of those areas. 2 or more comparative or contrasting conditions. This is when a document, in the document it says either or, it could be this or that, was listed. In the instance that these happened, you would sequence them in the order of admission. So if it was a patient came in with fever and vomiting, and but no, those aren't diagnoses. I'm trying to simplify. fever and vomiting, and there's no confirmation on which one is the principal diagnosis, or if they're conflicting, then you would just do fever, then vomiting, whichever one they have documented first is the order of admission, is how you would list those if it's not, if it's documented as either or, if it doesn't say specifically this and that, it says it's either this or it's that, then you'll just put both of them with the one that happened first listed on there. Complications of surgery and other medical care, you're going to sequence the complication as the principal, not the original cause of the surgery. The surgery area kind of gets, because there's a lot of things that can happen with that. When we get into this chapter, we'll kind of talk more in depth about the different things that can happen when we talk about complications from surgery, because different things come into effect when it talks about the healing process or when it happened could affect the code. But just generally complications of surgery, you're going to sequence the complication as the principal reason for the principal diagnosis. Uncertain diagnosis, in inpatient settings, if it is uncertain, if it just says probable, suspected, likely, questionable, or maybe, you should code it as if it were true, if that's what it was for inpatient settings. So for instance, if the patient came in with stomach pain and they suspected that it was kidney stones, but you weren't able to confirm that before the patient, just like, nah, I'm done, I'm gonna leave, I don't wanna be here anymore. Then if the documentation said probable kidney stones or suspected kidney stones, then you would code that as kidney stones. Admissions encounters for rehabilitation, you're going to sequence the condition for which the service is being performed. If that condition is no longer present, then you're going to report the aftercare code. So there are, again, we get into some of the specifics, or maybe an additional aftercare code, like a rehabilitation code, that you're going to put in there for the aftercare, depending on the healing and all that fun stuff. Admission from observation unit following post-operative observation or outpatient surgery. When the admission is for treatment of a complication resulting from a surgery, the complication code is sequenced first. So very similar when we're talking about complications. The complication code is going to be sequenced as the principal diagnosis. You're going to list that one first. Original treatment plan not carried out, you're going to sequence the results as the principal. So if we go back to that kidney stone, they come in, they have stomach pain, the testing did happen and said it was confirmed that it was kidney stones and that they needed them to be surgically removed, but the patient decides, no, I'm going to let it happen on its own, you would still sequence it is as it was kidney stones, so that's the reason, even though it wasn't carried out, the remainder, the surgery wasn't carried out, you would still sequence the results and why you were doing it. You'd still reference the kidney stones as the reasoning there, even if the surgery is not performed for whatever reason. Any questions on principal diagnosis? Again, it just kind of shows us the order of what you're supposed to list first. Principal, you're going to list first. Additional diagnosis or your secondary diagnosis, these are things that affect the patient, but they're not the principal reason. So these are going to be things that exist at the same time, and they could exist at the same time when they come in. They could develop alongside it. They may be something that's going to affect their treatment in the long run or the length of stay for that patient. So all of these would be listed as a secondary diagnosis. So when you're looking at the additional notes, any of these additional things, the clinical evaluations, therapeutic treatment, procedures, anything like that that provides secondary diagnosis to the original primary one, you're going to want to include that information as well. Things such as previous conditions and abnormal findings under your secondary, you have a few rules to follow. For previous conditions, if it is documented in there, but it has no bearing on whatever they're there for, then you don't code it. So if somebody came in and a condition was documented that they were a previous alcoholic with a leg fracture, could be that could be related, but it has no bearing on the current stay. Say they were a previous alcoholic and they slipped on a wet floor and they broke their ankle. Even if the physician diagnosed the previous alcoholism on there, but it has no bearing on the fact that they slipped and fell and broke their ankle, in that instance, then you wouldn't code it. You do have to read everything to see this, so you wouldn't add that in there. But say that they have that it was listed in, or that they were a previous alcoholic and they came in with liver issues, there's probably a good chance that that is related. So it is, then you would document the history condition in there as well. And there's a different way that you're going to document the history of things. Abnormal findings are not recorded unless there's a clinical significance that is documented. So if a test result came back in that chapter 18 and it was listed as abnormal or something was wrong, but it didn't affect anything in the outcome, it had something that was completely different, you wouldn't document it, you wouldn't code it in that case. Honestly, you would hope that the doctor notices that and they bring up the fact that you have abnormal findings and they do something about that, and then it would be coded because they're doing something else. But if it has no bearing on the case, then you would not document it under a secondary diagnosis. That's pretty much it for section 3. It's pretty short on the secondary diagnosis. Section 4, so this talks about the outpatient. So you're coding the reporting guidelines for outpatient. It is on page 66 through 68, the outpatient guideline. So if you review those a little bit. A lot of the information that's listed in there is a little repetitive of the first 3. If it's the same guidelines when it talks about you need to have, code everything fully, 3 to 7 codes, different things like that. So the first part of that is very similar. So most of the information I have listed on here is just the differences between your inpatient and your outpatient guidelines. But again, if you wanted to look through the whole thing, you can read through all the different notes on there. In the outpatient setting, they don't use principal diagnosis, they use first listed diagnosis. So that makes a little more sense. You list it first listed versus principal, but it's the same concept. They just call it something different in outpatient. With outpatient, you list first the code for the diagnosis, the condition, the problem, or the reason for the visit as being chiefly responsible. So the condition that why they showed up while they're there through the door, you're going to always list that as the first diagnosis. In outpatient, you do not code uncertain. So with the inpatient, if it said probable, you would code it out as it was. Outpatient, you do not code uncertain documentation. If it says uncertain, unprobable, you don't code that information. For ambulatory surgery, you're going to code the condition for which the surgery was performed. So if they came in with stomach pain and they had surgery and then it was found that they had kidney stones, the surgery was performed for the stomach pain. Chronic diseases may be treated chronic diseases treated on an ongoing basis may be coded and reported many times with outpatient, whereas an inpatient, you're going to code once for that encounter. You don't, if they were there, you don't code it every single time with the inpatient. But outpatient, you can code it as many times as the patient receives that treatment. You're going to code all documented conditions that coexist at the time. So you're going to code pretty much all those secondary things. You're going to code all of that within there as a primary or as a first diagnosis. You're going to code all of that information within outpatient. Patients receiving diagnostic or therapeutic services only, you're going to sequence the diagnosis condition as being the reason for that. So if they came in for some sort of rehab of the knee or something like that, you're going to code that as being the reason for the outpatient visit, not the surgery of it. Again, once we get into those chapters, it makes just a tad more sense. I did find this was not something that was in our book, but I thought it gave a pretty good quick overview of outpatient versus inpatient coding, so you kind of see the differences. It does have different billing. When we get into coding 2 and we start talking about your CPT versus your PCS procedural codes, they're a little bit different for your outpatient and your inpatient. So I just have kind of provided that as additional if that helps you kind of visually see some of the differences between your outpatient, your inpatient coding. So that is it for chapter 5, when we talk about the coding guidelines. Do you have any questions on guidelines, what to do first, what to do second? Okay. The guidelines, like I said, are available on Blackboard, course resources. Oh, way down here at the bottom. Let's move that up to the top here. The official guidelines for coding and reporting. So about 120 pages. Pretty much everything I talked about is all going to be listed in here. When I said it may say C section 1, C, blah, 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 blah. If you're looking at the guidelines, so you've got your section 1A, 1, 2, 3, 4, 5, 6, A, B, so it's going to reference specifically. So if you see that in the code book, it says C section 1B 16, you're going to go 1B 16, so you know kind of where, what they're referring to, what's the rule on whatever that issue is that you're discussing. So the assignments for chapter 5, I do have you doing all 3 exercises. The exercises are just 5 questions each throughout in the reading. I think exercise 5.1, 2, and 3. So 15 points total for that, and then you're going to do chapter 5, test yourself. Like I said, through that PowerPoint, I did try to highlight some of the things that you do need to reference to help you understand that information. Any questions on chapter 5? Oh, let me stop sharing. Stop myself. Bye-bye, everyone. Hold on, how do I stop?